Hello and welcome. This is going to be a presentation on biosafety and emerging infectious disease in EMS. We're going to talk about a few key components related to emerging infectious disease that might be considered useful. As you know, there might be a few things in the mainstream media and in the general public that's going around in conversation that would be considered emerging infectious disease. I'll touch base on the COVID-19 virus and talk about a few other relevant viruses that are going around this time of the year. And really what kind of forms of infection control we should be using, what we should be paying attention to in terms of public health announcements and disclosures. Oh, by the way, this is Michael Carr. I'm as of February 5th, the new medical director for Dekalb County Fire Rescue. So if I haven't met you yet, nice to meet you over presentation form. If you haven't met me yet, that's a picture of me. Before you ask, yes, I'm old enough to be a doctor. But as of February 5th, I'm fully functioning on board as a medical director and hopefully we'll be able to continue some of these informative presentations moving forward in the future. But this is a timely topic, and there are some relevant things that we want to discuss, so I'll just jump on in. Before I proceed, one of the things that I do in EMS, we wear many, many hats. I work at Emory University Hospital as an emergency physician. I'm a medical director for DeKalb County and also for Air Methods, Air Life Georgia. And finally, one of the things that I do is biosafety transport operations. So I actually travel around the country and I talk about this stuff, biosafety and biosafety transport, to various EMS systems and hospital systems, discussing emerging infectious disease and how to appropriately prepare an EMS system and EMS healthcare workers to deal with patients with high consequence infectious disease. And that's what I'm going to talk to you a little bit about today. So if you have any questions, certainly you can email me. I'll show you my email at the end. But I'm consider myself timely in that, sure, I'm on Twitter too. If you have any questions, just tweet me a question at mcarmd. Or Emory EM. One of us will get back to you, I'm sure, although I might be a little bit more responsive to the EMS type questions. So feel free to tweet me as you're watching this video, and I'll try to answer as best I can. So today I just want to review a few elements of infection control. So when we say standard and transmission-based precautions, what does that mean? This might be review to you. This might be something that you've heard of before, but essentially all public health recommendations, namely the CDC, is going to be built upon these foundations of infection control. So when CDC when they release recommendations to healthcare workers, they're going to say, for this emerging infection, we recommend standard plus droplet plus airborne precautions. So you kind of have to really have a grasp and an understanding of what that means and what type of equipment you would use in those settings. I'll talk about a few timely infectious diseases and threats that are applicable to our environment in EMS. And we'll talk about mostly how to identify, based on what you know, your foundation of infection control and some of the information about some of these bugs we'll discuss. We'll talk about how to isolate ourselves and how to isolate the patients from us, and also how to inform who you're going to call when you have a patient that's potentially infected with some kind of emerging infection. So those are all important things in EMS. And as you know, that photo probably looks familiar to you. As you know, there are many threats in our environment that we'll certainly be able to discuss. So let's first talk about some of the serious communicable disease threats. I'm going to focus on novel coronaviruses and novel and seasonal influenza. Well, I can talk about Ebola all day long, but I don't want to keep you on the computer watching a presentation for the entire day, because that's something that we could certainly go on for a while. If you're curious, I don't know if you can see the mouse, but this image here in the top right is going to be the coronavirus, and named based on its electron microscopy because it actually has a halo or a crown, which basically in Latin is corona. And, it actually has nothing to do with the beer. Although, if you look at the beer bottle, Corona, you'll see a picture of a crown. I believe it's over the name Corona. And that's essentially, a crown or halo, like I mentioned before. Down here in the bottom left is going to be the influenza virus, that greenish circular virus. And then the one all the way over to the right that kind of looks like a Mickey Mouse with a long tail, that is Ebola virus. Real quick on standard precautions and transmission-based precautions. When I say standard precautions, that's kind of a general term that it basically focuses on body substance isolation. So we're trying to reduce the risk of transmission from moist body substances. Basically, when you think about body fluid isolation, think of different things that you can do to separate blood and bodily fluids from between two people, for instance, between a healthcare worker and a patient. When I say standard precautions, try to think of a few things that might come to mind. Something as simple as gloves, mask, even hand washing. So these are all examples of standard precautions. We all know that person who doesn't follow standard precautions. Who's that person that you know who's putting in IVs without gloves? That's a failure of standard precautions. When I think of failures of standard precautions, I think of that time I tried to do an incision and drainage in residency. I was teaching a medical student how to do an incision and drainage of an abscess, and he was all donned in his appropriate PPE and standard precautions. I was not, because I was standing in the back trying to show him how to do it from a distance. I took one step up, tried to point to where he should be incising, and the whole thing popped and exploded all over my face. Yeah, I could taste that pus in my mouth. It was really disgusting. That reminds me every day the importance of standard precautions, body substance isolation. When I say transmission-based precautions, there are a few terms that you might be familiar with. Contact precautions is one of them. If you walk through a hospital and you see a patient on contact precautions, you might notice a yellow or green sign on the door, and you might notice a cart outside of the door of a hospital with gowns, gloves, and this contact precaution is designed to reduce the risk of transmission by direct or indirect contact. This is, you might have seen this before if you can think of a few examples like MRSA or C. diff. This is something where gloves and hand washing are really important, especially with C. diff. As it turns out, hand washing after you have exposure is part of contact precautions because the alcohol-based hand wipes or hand gels and hand foams, they do not evidently do not destroy C. diff as well as washing with soap and water, because C. diff has a pretty nice protective coating. Um, MRSA, cholera, C. diff, viral conjunctivitis, these are all examples of contact precautions. VHF down there at the bottom, that refers to viral hemorrhagic fever, Ebola virus, Marburg virus, or if you're a fan of the movie Outbreak from 1995, Mutaba. This was a viral hemorrhagic fever virus that was pretty well dramatized, and it's a really interesting story. In fact, I should probably preface this. It's a prerequisite for all of my biosafety lectures to watch Outbreak, to watch Contagion. Let's see, a few others. How about the new Nat Geo Ebola Hot Zone virus series? That was a pretty good one. And I can't think of anything right now, but if I make any movie references, I apologize. I'll try to warn you and have you go back and watch the movie afterwards. Next would be droplet precautions. So droplet precautions, this is something where, as you can see in this photo, when you sneeze or you cough, there are actually droplets that are projected out away from your mouth in the form of saliva. And bugs, as you know, like influenza and a few others, and many, coronavirus. These are all things that will be carried out into the droplets. Droplets, by definition, are large particles that are greater than 5 microns. With droplets, gravity is on our side. So we say, somebody who's coughing or sneezing or talking even, if a droplet is projected out of their mouth or nose, usually it's going to fall to the ground within 3 to 6 feet. So gravity helps us out. they do not remain suspended in the air. So that's reassuring. There are some bugs like this, pertussis, pneumonic plague, even group A strep, influenza, again, viral hemorrhagic fever. These are all transmissible through droplets. So if somebody's on droplet precautions, you might see that this time of the year. Seasonal influenza, as an example, would be considered a droplet precaution. What are they wearing? Well, they're usually just wearing a surgical mask. Healthcare workers entering the room should be wearing just a plain old surgical mask, something that's a barrier protection between you and the patient. And that's generally enough. If you have a patient that you're picking up and transporting, or you're bringing them to the hospital, and one of their symptoms is cough, maybe with or without a fever, just go ahead and put a surgical mask on them. And I would usually recommend putting a surgical mask on yourself, double protection. That's a very, very effective way to spread to stop the spread of droplet bugs. Now, you've probably heard of airborne precautions as well. This is something that's also very timely. As you know, there's a national shortage of N95 masks. N95 respirators are a type of airborne precautions if they're appropriately fitted. Airborne precautions refers to bugs that are less than 5 microns in size, and they can remain suspended in the air for hours. A few examples of this. If you are walking into the kitchen after somebody was cooking a steak, and you can smell the steak, and that smell is kind of lingering in the air for hours, that's something that's floating around and suspended in the air that's able to go up into your nose and latch onto your olfactory nerve sensors. And so those are likely less than 5 microns in size that you're smelling and activating your olfactory sensors. Think of a few infections that might be airborne precautions. Maybe you've seen airborne for tuberculosis. That's an example. Measles. Now those are bugs that actually are transmissible through droplets as well. But as it turns out, when they dehydrate and they develop these things called droplet nuclei. So picture the droplet dehydrating down to something smaller, less than 5 microns. Those droplet nuclei can float around in the air, and they can latch onto dust particles and be suspended for hours. These things can be inhaled over a great distance. These patients, in addition to being on airborne precautions with a negative pressure room, negative pressure rooms require 6 to 12 air changes per hour, or air exchanges, usually with a HEPA filtration system. This is some type of a private room. In addition to that, you are going to be wearing a NIOSH-approved N95 respirator. Now, you could wear the N95 respirator and still put a surgical mask on the patient. That's going to reduce the spread of droplets and I think make it less likely for some of these aerosolized particles to get into the air, and ultimately kind of reduce our chance of exposure to some of these bugs. Measles, varicella, tuberculosis, those are examples of airborne precautions. Now, I would caution you, I'll say this again, but I would caution you from overusing N95 masks. If you have a high clinical suspicion that somebody has measles or COVID or something where airborne is routinely recommended, you still shouldn't use the N95 until it's a confirmed positive. Mostly because, and I'll talk about this a little bit more, we need to ration these masks for when somebody is confirmed positive with an airborne precaution bug. And secondly, 99% of the time, these bugs are not going to be transmissible even if you put on a surgical mask, unless you're doing something that's aerosolizing this bug into the air. So aerosol producing procedures like RSI, like even nebulization, there are things that we're going to nebulize or aerosolize these bugs into the air. You could consider wearing one if somebody, an N95 that is, if somebody is extremely high risk, likely had a positive exposure, for example, to COVID-19, and you're going to be doing an aerosol producing procedure. Other than that, current recommendations are Stick with the droplet precautions, routine precautions, standard precautions plus droplet precautions for anybody with respiratory symptoms. So getting back to some of these bugs, I do want to focus on some of these just so you have a little bit of a background with coronaviruses and what everybody's talking about with that. I won't talk about Ebola today, but I can certainly answer any questions that you have about it. And then we'll talk about novel and influenza, novel and seasonal influenza as well. SARS. SARS is something that you might have heard of back in the 2003-2004 time, where this basically is severe acute respiratory syndrome. SARS is something I remember. I was actually, well, I'm dating myself here. I was back in high school, and I was going on my first international trip abroad to France as part of the school group. And I remember people wearing masks around the airport, similar to what we're seeing today. Oh man, I just dated myself as a millennial. That means nobody's going to listen to me from now on. Anyway, SARS, there were about 8,000, a little over 8,000 people known to have been ill in that many countries, 29 countries. And 8 people in the US were affected. Out of all the people who were infected, 700, a little over 750 people died, 774. We haven't seen this since April 2004. Maybe that's just because it's not being reported, or we've developed a level of humanity, like immunity within our humanity. So SARS is not considered a serious infection anymore. That's certainly possible. Anybody seen these symptoms before? Have you ever seen a patient with fever, headache, malaise, myalgias, diarrhea, dry cough? I have, every day. This is something that we see routinely, especially in the winter months. And we can't make clinical decisions just based on the clinical symptoms. There are other things that we have to consider. SARS is transmitted by respiratory secretions, so droplets. There's also some evidence of airborne transmission. Usually, as I mentioned, it's usually based on aerosol-producing procedures, so I'll mention that again in a few minutes. And it's been transmitted in a healthcare setting. There are cluster outbreaks in Hong Kong and Toronto. Usually, it was when PPE protocols or infection control protocols were not being appropriately followed. So it's so important to follow current recommendations of the CDC and World Health Organization. This is just when we had the SARS outbreak. There was a cluster up in Toronto, Canada. Here's another movie reference for you. If you've seen Contagion, they send a medical epidemiologist. This is Kate Winslet. They sent a medical epidemiologist out to figure out where the epicenter of this outbreak is, the virus of question in this movie. Well, basically, they sent Kate Winslet up to Toronto, Canada in 2003 because Canada was looking for some outside help related to this infection. So they sent her up there and did some work to find out, if you see here, look at these patients over here on the left, 7 ER visitors, 7 ER patients, hospital staff, ER nurses, clerics, housekeepers. They found that there were some risk factors like overcrowding. There's some open observation areas for respiratory complaints, nebulized medications going on, poor compliance with hand washing, and unrestricted access to visitors. Now, when I see these risk factors or these elements of the spread of disease in Toronto for SARS, I picture, I don't know if you've ever been to a hospital that has an asthma room before. Where I trained in residency up in Newark, there's actually an asthma room. If somebody came in with wheezing, they'd put them into a room. There were a bunch of trees, Christmas trees on the side of the walls. They could hook up an aerosol mask and nebulize some Duonebs or something like that. Anybody with wheezing went into that room, regardless of whether or not they had asthma. That's really concerning, and those asthma rooms are hopefully starting to go away. Because if there's an infectious disease that's potentially causing some wheezing, that's entirely possible, like SARS or MERS or COVID-19, then that disease potentially could be aerosolized into the air and infect the people who are sitting right next to you in that asthma open observation area. Think of all the kids that are walking into that room saying, "Mommy, Mommy, did you finish your treatment yet? Are you ready to go?" Think of the ER clerks who are going in to finish the registration for the patient. Think of all the nurses in and out changing the treatments. These are all patients who are exposed to these bugs that are getting aerosolized. So, aerosol producing procedures, nebulized medication is one of them. If you are inhaling a nebulized medication like albuterol, um, particles and droplets from inside your lungs are getting aerosolized when you exhale. Airway suctioning, before RSI, that's a way to aerosolize some of these droplets and essentially create droplet nuclei. Intubation, positive pressure ventilation, so CPAP, BiPAP. There's some things that are going to produce some particles floating around in the air. A little bit more about SARS, and this, you may think, oh, this is outdated. We're not going to see SARS anymore, which may be true. But most of what we're learning and most of what we're seeing with the current coronavirus, COVID-19, essentially is based on SARS, our SARS experience, or based on our MERS experience. Um, a little bit more about the Toronto EMS system. Think about 526 paramedics requiring quarantine during this cluster outbreak. Um, up front, there's no evidence the virus was transmitted from an asymptomatic individual. Before that was known, we saw a lot of quarantining that was being done. As it turns out, we learned that the most of the transmission of this illness was during the second week of illness. It's because that's when you're most contagious, when you're most symptomatic. So the Toronto EMS system got a little smarter, I guess, with the second cluster outbreak. The first cluster outbreak, they had 234 medics on home quarantine. So Dekalb County has what, 650 employees, somewhere around there. Imagine taking 230 of those employees and saying, "Oh, don't come to work, stay home." That would be a devastating impact on our system, on Dekalb County. Imagine that, and that's why the CDC and these health organizations have to take extreme consideration and precaution with making recommendations. The second cluster outbreak, they smartened up a little bit. They said, okay, so we have 292 medics we have to quarantine. They did home quarantine for the symptomatic individuals, but if there was an exposure and it was unknown if they were symptomatic or there were no symptoms yet, they did WQ, that's work quarantine. So they said, okay, you still have to come to work. If you develop symptoms or fever while you're at work, then we'll isolate you, we'll send you home. And that seemed to work a lot better for the system. So this is where those standard and transmission-based precautions are really important. And if you're going to be reading recommendations from the CDC for healthcare workers, you have to know about these. Really important. So for SARS, standard plus contact plus airborne plus eye protection. And we want to limit aerosol-producing procedures. There's no treatment for this. There's no vaccine for this. SARS is a novel coronavirus, just like the one that we're seeing right now. SARS is a novel coronavirus. We have no cure or no treatment. There are some antivirals that are being experimented with, but there's no cure that we know of. MERS. This one is still actually an ongoing infection. We first saw it in Saudi Arabia. This is also a novel coronavirus, and it's most likely acquired from an animal source. It's thought that MERS actually was transmitted from camels to humans. Classically, though, coronaviruses kind of dwell in bats and snakes. That's where we see them the most. So maybe a bat or a snake came in contact with a camel, and the surface proteins had mutated enough that they were able to infect a camel, and maybe there's some similar tissue between a camel and a human in terms of the oral mucous membranes or fecal mucous membranes. So humans essentially were starting to get infected. That's one of the thought processes behind this. Signs and symptoms. Have you ever seen those before? Cough, fever, shortness of breath, diarrhea, nausea, vomiting. Yes. We know from MERS that the incubation period for this type of coronavirus is 2 to 14 days. And transmission is primarily through contact with respiratory secretions. Again, there's still some thought that aerosolization procedures, aerosol producing procedures, can infect people with with particles less than 5 microns. And the recommendations for the incubation period for COVID-19 are actually based on MERS data. So MERS is primarily Saudi Arabia, the Arabian Peninsula, and we did see a few cluster outbreaks that are worth mentioning. There was a cluster outbreak in South Korea that was devastating, where over 3,000 people were quarantined and 700 schools were closed. Do you think that would have a significant impact on our society? Yes, absolutely. MERS, this is kind of to bring up another important point. We have these clinical symptoms of fever, cough, shortness of breath, some diarrhea. You can progress onto pneumonia, and that's great if you have the symptoms. But really, we should not. Our light bulb for MERS should not be going off unless we have some risk factors or some criteria to make us think that. So think about travel in the last 14 days to the Arabian Peninsula. Signs and symptoms of this bug, close contact with anybody who was tested positive or met those criteria within the last 14 days. Those are things that are going to send off your or turn on your light bulb and say ding ding ding, I've got to pay attention to this patient. That's why it's so important to ask. Anybody gets in the back of your ambulance with cough and fever, respiratory symptoms, even if it's not part of your routine protocols, ask, have that conversation. Have you had any recent travel within the last 14 days? So important. That one question, you get so much information. Have you had any exposure to anybody who's traveled to any countries of concern over the last 14 days, you could even say. Those two questions alone, if they say no and no, you're done, right? Unless they offer information like, oh, actually, I have a spouse who works in the CDC and is working on COVID-19 right now in the laboratory setting and also has similar symptoms. Well, okay, that might raise your suspicion as well. Most of the time, we're not going to be transporting those patients, but if you're curious, just ask. The CDC recommends standard plus contact plus airborne plus eye protection, same as MERS, and we're going to limit aerosol producing procedures. Again, all the data about airborne transmission of these novel coronaviruses is based on really limited data related to aerosol producing procedures and primarily suspected during the Toronto outbreak for SARS. That's why the CDC is playing it careful and saying for confirmed positive MERS, SARS, or COVID-19, airborne precautions is recommended. If it's suspected, however, if it's a suspected person under investigation, still routine droplet precautions, so surgical mask on you and the patient. That's all we have to do for now. Chances are it's most likely flu or another virus, right? If we roll the dice and take our chances, that's most likely what's going on. COVID-19 though is something that is timely, and the numbers are changing as we speak. Last night we broke 100,000 cases internationally, and we have 3,400 deaths. So over 2,000 cases 200 cases are reported in the U.S. so far. Again, that's a new number as of last night. And essentially, we know this is most likely COVID. Most likely came from an animal source. It's thought that it was initially picked up in an open seafood market in China. And as I said before, these coronaviruses tend to dwell in bats and snakes. So it's thought that bats or snakes, maybe some fecal material or guano from a bat, was ingested or became plastered on a fish or some kind of crustacean that was being sold in an open market, and bam! All of a sudden we have a mutated virus that likely mutated in snakes and has infected humans, and that's where we think it first started. We're talking about case fatality rates. You might even hear mortality rate of COVID-19 on the news. It is too early to tell at this point. So, just as an example, there's the current population of China is about 1.5 billion people. China has 1.5 billion people. In China, we have a little over 80,000 confirmed cases of COVID-19. So percent of the Chinese population alone with COVID is going to be 0.0005. I'll say that again, 0.0005 percent. So that's 1/20th of 1%. That's hardly anything when you think about it, right? And yet this virus is just blown up in the media. Um, Essentially, people with underlying medical problems are going to have increased risk of complications. That's the case with any respiratory bug. And patients can progress to more serious illness in the second week of infection. That's when we tend to see the serious symptoms setting in. At this point, it's not suspected, but it's really unknown if asymptomatic shedding or spreading of the virus can occur. Um, can you think of any virus that is actually transmitted in patients who are asymptomatic? So without any symptoms at all, you can transmit this virus. I'm going to make you think about that, and I'll reveal the answer in a few slides. I bet you'll be surprised. COVID-19, have you ever seen these symptoms before? Fever, cough, shortness of breath. The incubation period is 2 to 14 days, very similar, and this is based on MERS and SARS. The data primarily. And we know that most transmission occurs through contact with respiratory secretions. So when we say PUI, that's a person under investigation. So when Kate Winslet was dispatched up to Toronto, Canada, she investigated all of the people who were confirmed positive, but she also investigated suspected cases of SARS. And this PUI, these people that she was talking to, is basically how these medical epidemiologists develop their recommendations for public health. So in the end of January, CDC recommended these guidelines: clinical features and risk factors. So if we were going to consider anybody a PUI, person under investigation, if they had fevers or signs and symptoms, and healthcare workers who had close contact with laboratory confirmed COVID. Fever and signs and symptoms plus a travel to Hubei province in China. Fever and signs and symptoms with a history of travel to mainland China. That was it initially. As the disease spread, March 2nd, they changed their PUI criteria. And that, in fact, it was a little earlier than March 2nd. But, we said fever and signs and symptoms, and anybody who had confirmed laboratory contact with a confirmed laboratory case within 14 days, history of travel to geographic areas. So at this time, there were 5 different areas that were of concern. So Japan, Iran, China, South Korea, and Italy. So those were the 5, and also fever with signs and symptoms, and no other source of exposure has been identified. So if flu is negative, if RSV is negative, if all of our respiratory viral panel is negative, then you could consider checking for coronavirus. That's what they resorted to. And now, if you check the website as of 2 days ago, they say, just use your best judgment. So the PUI criteria are gone, and we're just saying, well, you should just use your best judgment because now the test is more readily available and we can test a lot more people. So my guess is somebody's going to make a lot of money on this test. So now that we're testing a lot more people, it's really open season. I still would caution you, though, patients are not going to be routinely checked for COVID-19 until all of the other tests, like influenza, RSV, blah, 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 are negative, or they have those travel risk factors. If they have those travel risk factors plus symptoms, they're going to be checked. Right now, the CDC is recommending for confirmed positive coronavirus, COVID-19, standard plus contact plus airborne plus eye protection and caution with aerosol-producing procedures. That's purely based on recent coronavirus outbreaks like MERS and SARS. And we're going to minimize our exposure. Treatment at this point is supportive. There are a few antivirals like ritonavir or something like that. I can't even pronounce it. That's being checked to see if it helps prevent the spread of COVID-19, but there's no vaccine or post-exposure prophylaxis otherwise. So just to review, respiratory illness with significant mortality Now, I say significant mortality because it's worth mentioning. There is, there are over 3,000 people who have died worldwide. These are people with risk factors and comorbidities we're seeing, and elderly. So primarily that population. Healthcare workers, us, that's us. We're at risk if we do not implement infection prevention procedures. So, focus on infection control or source control on all patients with respiratory symptoms. If somebody has a cough and fever, put a mask on them. Put a mask on yourself. That's gonna be plenty for these respiratory symptoms. If you're performing aerosol producing procedures, like you're intubating somebody, you're putting them on CPAP, BiPAP, then you can consider, if they're extremely high risk for COVID-19, then you can consider adding airborne precautions, but it should not be routinely used. Influenza virus, worth mentioning this for comparison. So just want to hit a few high points with seasonal influenza, and I'll also just have a few slides on the novel, or the avian bird flu and that type of stuff. So the novel influenza viruses. Influenza A and B are primarily the ones that we see. Influenza has H and N surface proteins. That's hemagglutinin and neuraminidase down here at the bottom. That's just, as far as EMS is concerned, all we have to know is that's how we're going to classify them. So there are different strains and there are different mutations of influenza that change from year to year. So that's called drift, influenza antigenic drift. They change from year to year, and that's why we have seasonal influenza variation. When we have an antigenic shift, that's a complete mutation of a new protein that we don't have any immunity to at all. We start to see novel influenza viruses like avian flu and all those scary ones that you might have seen in the media. So this answers the question I posed before. Viral shedding for seasonal influenza happens a day before symptoms. Is that scary? Yes. And this is a medical epidemiologist's nightmare. Somebody who's not symptomatic is spreading the virus. So seasonal influenza is one of the viruses that does that. This is transmitted by direct and indirect contact with infectious droplets. Droplet precautions are key. Contact precautions are key, because if somebody sneezes and gets these droplets in their hand and they put down their hand on the table, somebody else comes by within a few minutes and touches that same spot and then touches their mouth, those droplets were just transmitted up to your own body. So have you ever seen these symptoms before? Fevers, chills, cough, sore throat? Yes. So that's why it's so important on anybody with a respiratory illness, just source control, put on that surgical mask, and keep those droplets to the patient's self. Patients are more likely to be infected or rather have serious complications of seasonal influenza if you are old or really young, or you have chronic medical conditions. And just as an aside, get the vaccine. We know that if you get the seasonal influenza vaccine from year to year, your chance of dying of the flu is greatly reduced. The vaccine is safe and effective. It can't give you the flu. Yes, you can develop a viral syndrome like fever or just feeling under the weather, but it cannot give you influenza virus. That's just your body's reaction to the vaccine. There are some treatments like Tamiflu that can shorten the duration of flu, but there's really nothing that's going to stop this virus. It's really your body that needs to fight it off, and you can prescribe somebody Tamiflu to if they're immunocompromised. So I do it every once in a while because it'll cut a day or two off, and it has been shown to reduce the chance of developing serious complications in immunocompromised patients or elderly patients. And it also spreads it stops the spread of the flu. So somebody who has the flu, if you're going to be exposed to them, let's say a family member has a confirmed positive influenza and you are exposed to them, if you take Tamiflu, you're less likely to get the flu. So it does work as a prophylaxis. A few slides on avian flu, bird flu. CDC is going to issue these occasional warnings. You're going to see it in the media covered a lot more. The last we saw concern for bird flu was in March of 2017. There's some examples: H7N9, H5N1. These are all, variants or novel influenza viruses. So this is where the surface proteins has changed enough so that we don't have immunity established as a humanity. Human exposure to the virus is primarily, for H7N9 as an example, it's a type A influenza virus, but we're primarily getting it from birds, from poultry. Where do we see open farms of poultry where there's just chickens and birds hanging around? Yeah, China. That's why these tend to come from China primarily. There were 5 waves. There's, human cases were a little over 1,500. And there's a significant mortality associated with this. Of those 1,500, most of them were directly exposed to birds. Excuse me. It's rare to have human to human spread. For novel influenza, the CDC recommends standard plus contact plus airborne. This is primarily because this is a highly lethal bug. There's not too much known about avian or novel influenza, so it's not known if aerosol-producing procedures will increase our risk of airborne spread. That's why the CDC and WHO recommend airborne precautions in addition to standard and contact. When we see pandemic, what does that mean? So a novel influenza, we have to meet these 3 criteria to be considered a pandemic influenza. Has to be new, where there's no human immunity. Has to make you sick, has to cause a serious illness, and has to spread efficiently from person to person. So some differences between the seasonal flu and a pandemic flu. Infectivity is a little bit higher in the pandemic, and a pandemic we're only going to see a few times every 100 years. 500,000 U.S. deaths, those are numbers from the Spanish flu in 1918. So you can have up to 500,000 U.S. deaths. That's a lot. 100 million deaths worldwide. These outbreaks are going to last a lot longer than seasonal influenza, and also the recovery time is going to be considerably longer. It can affect anybody. We know seasonal flu affects elderly and the ill and immunocompromised or comorbid conditions. Pandemic or novel influenza, this just does not discriminate. Anybody can get infected. And here are some examples of a pandemic influenza that happened within the last 100 years. Spanish flu, Asian flu, Hong Kong flu, and recently, H1N1. We got lucky with H1N1. This was a novel influenza virus that now we have established humanity to. There were only 12,500 cases in the U.S. that died related to H1N1. That could have been a lot worse. And it's thought that the massive public service announcements related to infection control was to play with that. These days, it's a lot easier for us to spread news and to spread public service announcements than, let's say, 1918. Cough etiquette, hand hygiene, isolation of suspected cases, and good infection control. These are all things that are going to help us stop the spread of pandemic influenza. Timely recommendations will come from public health and will likely be transmitted down to you via email or text or contact through other means, through your supervisors. A few slides on just recognition and management, just to kind of summarize everything that you just saw. By the way, if you don't know what this photo is, you probably haven't been watching the news. This is coronavirus, and again, this is an electron microscope photo where you can see that halo or that corona we were talking about earlier. And when I used to show this photo, I used to give this lecture before this outbreak and still talked about coronavirus, usually SARS and MERS. I'd show this photo and nobody would know what it is. Now everybody knows what this is, so it's pretty funny. Identify, isolate, and inform. Remember those 3 I's, because that's something, if you're concerned about it, that means you need to go down this protocol. You have to ask yourself the risk questions. What's the chance that this patient actually has a serious communicable disease? And do they have those signs and symptoms? And do they have the risk factors from the geographic location where these outbreaks are kind of coming from? So travel history, known exposures or positive exposures, plus signs or symptoms. That's going to be your own personal PUI, person under investigation criteria. Let's use COVID-19 as an example. A patient, a patient who gets in the back of your ambulance with a cough and a fever. Well, you should put a simple face mask on those patients, surgical face mask. Put one on yourself as well. If we say there's fever, cough, and difficulty breathing, and any of these areas that the CDC has listed as level A or highest concern for travel, or sorry, what is it? Level 3, highest concern for travel. These are these are questions that when you ask and you get a positive answer, you should have a light bulb going off in your head. Sir, have you traveled to China, Iran, Italy, Japan, or South Korea recently? Do you have the fever and the cough and the shortness of breath? Yes, those are going to send off some concerns in your head. And when you call ahead to notify that you're coming to the hospital, tell them that they meet high risk criteria so that they can prepare. At this point, that's still the recommendation. As this virus spreads and more people get infected, recommendations are going to change. So I'll try to update you on those. Just as an example, PUI criteria have already changed on the CDC website. Any patient who comes in with cough and fever, just put a mask on them. Source control and isolate. That's still the recommendation. It is not recommended to wear an N95 mask because chances are, at this point, it is not COVID-19. Isolate. So you want to limit the number of people who are exposed to this patient. Um, you know, one person in the back of the ambulance. Don't put more than one person in the back. Make the intern get in the back with the patient. No, I'm just kidding. Sorry, interns, I'm just kidding. Determine what PPE is required. Well, you're going to do the recommended standard-based precautions that's according to the CDC to any patient with a cough and a fever, which is source control with a surgical mask. 6-foot rule. That's also something you can add to the surgical mask application. So the 6-foot rule is going to protect against droplet exposure. Remember those droplets, they fall to the ground. Gravity helps us because they fall to the ground. Okay? Consider reducing aerosol producing procedures if possible. However, if a patient needs a nebulization, for example, you should not withhold that treatment. Protect healthcare workers by reducing medical equipment handoffs, for example, to minimize contamination. And inform. Finally, we have a person that's high risk where you're considering somebody has, COVID-19 or MERS or let's say Ebola based on their travel history. Inform your supervisor, inform me, inform your local health agency. I would recommend starting with your supervisor because this, as per protocol, we should escalate that in that fashion and try to get a plan together with how we're going to deal with this. If you're not sure, just call and ask and we can try to answer. So I already hit some of these, but basically limit exposure, source control with a simple mask on the patient and on the healthcare worker. Let's say that there is a confirmed positive COVID-19 that you're transporting. I put this in here just as a consideration. Confirmed positive where airborne precautions have already been ordered. So consider the wearing 95 if you're in direct contact in the back of the ambulance, especially if you're doing aerosol producing procedures. But think about the driver compartment as well. The driver should also wear an N95 with a confirmed airborne precaution patient. The driver should also wear an N95 because these droplet nuclei get into the air handling system and can be exchanged up to the front as well. Afterwards, just consider I wanted to say, just consider wiping down your equipment with EPA registered hospital grade disinfectants, right? This is the gray top or the purple top. Pay attention to the wet time on the back of the container. It tells you how long it has to sit wet time in order to disinfect. As far as waste management is concerned, Category A waste, the only bug that we're going to be seeing with Category A waste is Ebola virus disease. Biosafety transport teams, like the Grady Biosafety Transport Team or the Atlanta Airport Biosafety Transport Team, they're going to be specialized at transporting these patients with Ebola virus disease. So they should be the ones worrying about the Category A waste. All of the other, novel coronavirus, novel influenza virus, those are considered Category B waste, and that's still regulated, but we're putting it into a red bag instead. If you have a possible exposure, alert your supervisor. Uh, if a person meets your PUI criteria, they're high risk because they're exposed to somebody who had a known positive COVID-19, or they traveled within the last 14 days to any of those 5 countries, and they have the signs and the symptoms. Keep that person's contact info, alert your supervisor. Maybe we want to follow the patient until they're confirmed positive or negative. Okay? Chances are they're going to be negative. Chances are we're in the peak of flu season. Chances are it's going to be flu or something else instead. Okay, so that's pretty much it of all the information I wanted to cover. Just to kind of give you some resources here. The CDC is a great resource. They're updating the website hourly. Follow the interim guidance for EMS systems. That's going to give you step-by-step protocols. That's going to give you PUI criteria. That is constantly changing. So stay up to date with this. AsperTracy8.hhs.gov, that QR code there, that's just an infectious disease playbook. Focusing on infectious diseases like Ebola virus, mentioning a few things like novel coronaviruses, and it'll just have some additional points. Just want to close with a comparison. So we talked a lot about influenza today. We talked a lot about novel coronaviruses. So deaths due to coronavirus so far are about 3,400 this year since the outbreak started. Internationally, what do you think the deaths due to seasonal flu are? Yeah, internationally, our seasonal influenza-related deaths are over 85,000. And yet, we don't really see that being mentioned too much in the news or mainstream media or even public health. We're just so fatigued and maybe used to the idea that seasonal influenza is bad. Put a mask on everybody with flu symptoms. It's so important. Wash your hands. Wash with soap and water. Use, the Purell gels in between patients. That is plenty to kill off the influenza virus. If you have symptoms, reduce your exposure to other people. Put on a surgical mask. Simple things like that are so effective at spreading the flu. So 85,000 people internationally have died from a flu-related illness, seasonal flu, whereas only 3,400 have died from a coronavirus-related death. So that's pretty much it. If you have any questions, that's my email, or as you saw earlier, you can tweet me a question. Happy to answer anything as best I can. The goal for this was to be in under an hour, so I came in under an hour. Hopefully this was informative to you. If you have questions, just ask, and we'll try to roll out some policy and practice kind of changes and updates as the CDC recommendations are changing. Thanks so much for listening, and it was really a pleasure to meet you over presentation format. But if you see me around campus or you see me out on the road, go ahead and say hi. If you have any questions, I'm happy to answer them. Thanks again, and I hope you have a good rest of your day.